So good afternoon, everyone. Thank you for joining this session, and thank you, Dr. Supri, our director, coming here, and to Dr. Andrey Dobre Pasulupat V Indonesia. Hopefully, it's not wrong. So welcome to Indonesia. So today we have a session. Our expert is Dr. Andrey Yarovoy. He is ophthalmologist specialized in retinoblastoma treatment, and he will share his experience on local treatment like plaque brachytherapy, which is not available yet here, and we hope we can learn from you. So maybe I ask Prof. Tati first to give some introductory remark. Please, Prof. Tati.
So thank you very much everybody. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat bagi kita semua. Good afternoon everyone and very warm welcome to all of you. To our CEO of the hospital and also Dr. Andrey. So it's truly my pleasure and honor to welcome you all in today's the Retinoblastoma Local Treatment Update and Exchange Forum, a part of continuing commitment of knowledge sharing and multidisciplinary collaboration with the IRAS and also the Cipto Mangunkusumo expert. And today's session is particularly special as we privilege to host Dr. Andrey Yarovoy, an esteemed expert from the ophthalmic Oncology and Radiology Department of the SN Ferodov Eye Microsurgery Center in Moscow, Russia. And he is an ophthalmologist, but dedicated the whole his practice doing the plaque brachytherapy irradiation for retinoblastoma, as you mentioned yesterday. And it's a very special case happened nicely in Russia that probably not easy to be happen in Indonesia, since that we follow the regulation from our regulatory body and safety of atomic energy Bapeten. Using radioactive sources have to be under the radiation oncologist, radiologist, or nuclear medicine for the safety reasons. He will be sharing his insight on local treatment option for intraocular retinoblastoma, the topic that is not only highly specialized but also critically relevant for our pediatric and oncology practice. On behalf of all the retinoblastoma expert group from our hospital, and also not only here, but we have also friends in the Zoom, because this one is the hybrid event. I would like to express our deepest gratitude to Dr. Yarovoy for joining us, especially traveling so far until here and for sharing his experience with us. And thank you also for Jakarta Eye Center to allowing you to be with us today, this afternoon. We hope that this forum will spark meaningful discussion, foster collaboration, and enrich our collective knowledge to improve the care we provide to our patients. Thank you once again for being here, in person here, or also friends that are joining via Zoom. Let's make the most of this opportunity to learn and do a lot of connection with your place, because as it is mentioned by Dr. Handoko, that we still have no capability right now to do the plaque treatments, since that we have still have no that plaque. So thank you very much. Thank you.
Yeah, thank you so much, Prof. Tati, for your introductory remark. So now we will invite Dr. Supri. Maybe you have some comment and introduction for us, please.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera bagi kita semua. Good afternoon and warm greeting to everyone. Welcome to our esteemed guest, Dr. Andrey. It's truly an honor for us at RCM to welcome Dr. Andrey, and renowned expert in ophthalmology, oncology. Today we address a very important topic retinoblastoma, one of the most serious eye cancer in children. It requires swift, precise, and technology-based interventions. We believe that advancement in medical technology have paved the way for new effort to preserve both vision and life. And Dr. Andrey is here with us today to share with us about his expertise on this field. Thank you, Dr. Andrey. At our institution, Cipto Mangunkusumo General Hospital, we highly emphasize a multidisciplinary approach. Retinoblastoma cannot be managed by one specialist only. It requires synergy among oncology, pediatrician, and radiation oncologists, and of course, ophthalmologists too, and also other support from many disciplines, not just inside the institution, but collaboration are needed to move forward to take this disease. Dr. Andrey present today symbolize the kind of international collaboration we strive for. We believe that I believe that sharing knowledge and experience like this strengthen our capacity and enhance both survival and quality of life for our patient. Thank you, Prof. Tati and everyone who have invited Dr. Andrey to visit us and made this event possible. May this event be the beginning of broader and ongoing collaboration. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Supri, our director. And maybe Dr. Supri, we will give some souvenir to Dr. Andrey. So yeah, from the hospital, maybe Dr. Andrey, our CEO will give you some gift. And also there's an additional souvenir from Prof. Tati. Yeah. Okay. Okay. Yeah. Thank you. Thank you, Dr. Supri, our CEO. So now we will invite Dr. Andrey to give a lecture for us.
Not work yet, but gifts. So we'll start. Dear colleagues and dear Professor Tachi, it's a very good idea to make such a session here among practical doctors, and not only at the conference stage, but in a real hospital in the walls of real practice. As you can see, I'm an ophthalmologist, first of all, and our clinic is a multi-field ophthalmological clinic, which covers all types of ophthalmology. And there is ocular oncology and radiotherapy department, and we deal with all types of ocular tumors, intraocular, orbital, eyelid, and so on. And the main topic in our practice is, of course, retinoblastoma. So I will present some our experience in retinoblastoma treatment. I'm sure that, and maybe I am sorry that there will be many pictures for ophthalmologists, not for oncologists or radiologists. But I hope that it will be clear. If not, I'm ready to answer any question or maybe to make some explanation. So let's start. So retinoblastoma is the most common intraocular tumor. It's well known for everyone, and usually it presents before 5 years of age. The main treatment task is to preserve eye alive, to preserve eye, and to spare vision if it is possible. There are several treatment approaches to retinoblastoma. Historically, the first one was eye removing enucleation, but it is not a very good variant. So the most modern approach is eye-sparing treatment. And first of all, using chemotherapy, intravenous chemotherapy, intraarterial, it's a so-called local chemotherapy, and intravitreal chemotherapy right into the eye. And another branch of local treatment is ophthalmological or focal treatment. Brachytherapy using eye plaques, thermotherapy using infrared laser, and is in some selected cases cryotherapy. External beam irradiation has its own place, and we will talk about later. Enucleation is still one of the options for patients, for children at the late stages of disease. And nowadays we use in every case orbital implantation for better cosmetic outcome. Here is our children with monolateral enucleation with one eye, and cosmetic results is not bad. So the modern retinoblastoma paradigm include chemotherapy as the first line treatment, so-called chemoreduction. It may be local or systemic, and the second branch is a local treatment, so-called consolidation. We also in our clinic use chemotherapy, intraocular chemotherapy. We were the first in Russia to do that in 2011, and nowadays it is a very useful approach in chemotherapy, especially for vitreous seeding. Vitreous has no vessels, so there is no straight way to make chemo effective. And it may be intracameral and intravitreal, and it is a rather effective approaches, one of the main approaches nowadays. Here is the example of retinoblastoma that group D, that was not treated by systemic intravenous chemotherapy, but only by local chemotherapy, 3 courses of intraarterial and 3 intravitreal injections. But in the majority of cases need to be treated with different approaches, combining all types of focal or local treatment, and brachy and laser and cryotherapy. Here is the example of our patient with the only eye that there were 36 lesions on the eye fundus. According to groups, to group staging, here's our patients, and unfortunately, we do not have a patient at a very early stage like group A or B. Majority of cases is group C, D, and E. Depending on stage, there are different approaches. Here is the examples, the chart, how many treatment approaches are in need to treat depending on stage. There are, as we can see, there are only 1 or 3 approaches in group A, and group D need to have all 3. Laser thermotherapy is the first and the most often used treatment. We can deliver laser treatment either by transpupillary, by ophthalmoscope, and by transscleral probe. Thermotherapy is a heating of the tumor, and here is the example of heating of small tumors, whitening of immediately after procedure, and in several months it results in scarring without active tumor. Here's also example of multiple tumors that cannot be treated successfully by any other method. To treat the peripheral tumors, we should depress the sclera and to see the lesion and to deliver the radiation. So this is the picture of laser delivering on peripheral tumors. There is so-called cavitary retinoblastoma, when it is differentiated and relatively benign type of retinoblastoma that is not good for chemotherapy or radiotherapy, and we tried to treat that type with laser therapy as well. An interesting thing that laser cannot be absorbed good by white tissues, and retinoblastoma is white, not pigmented tumor. So we proposed a special mode for step-by-step laser treatment that in several sessions we can reduce the tumor. Here is this example how it is work. We induce pigmentation, and this pigment absorbs laser energy, and step by step we reduce the tumor. So I have correct picture. It's a pity that I think there are few ophthalmologists in the audience, and maybe some pictures is not quite clear, but nevertheless, I will show our experience. So, just a moment. So we try to analyze some variables, some factors in thermotherapy success. Among them, the thickness of tumor, location, and number of sessions, and so on. Another very important option in treatment retinoblastoma is brachytherapy. Brachytherapy is the first method of treatment intraocular tumors, especially uveal melanoma, and vascular tumors, and retinoblastoma as well. Brachytherapy is widely used in the world, and different sources are in use. First of all, ruthenium, and in Russia we use ruthenium and strontium plugs. Since 2007, we have treated 278 patients with retinoblastoma, and brachytherapy was fulfilled in 163. All these patients were heavily pretreated by all kinds of chemotherapy, intravitreal, intraarterial, and even 8 eyes were treated by external beam radiotherapy. Plugs. We use ruthenium plugs in 96 eyes, strontium plugs, and combine ruthenium and strontium in 16 eyes. And ruthenium and strontium are better emitters, and with not very deep effect of electrons. There was no clear information concerning radiotherapy doses for brachytherapy. In the literature, there are different various doses from very low to very high, and there is no information concerning strontium brachytherapy doses at all. So we tried to use different doses, and it was shown that optimal dose for ruthenium is 89 gray, and for strontium about 140. We distinguished, we saw that there can be several modes of brachytherapy. The most often we use one field irradiation. The example of ruthenium brachytherapy and of strontium brachytherapy effect. Multi-field irradiation of multiple retinoblastomas. Plaque transpositioning within one surgery procedure. In some cases, we use 2 plugs simultaneously. And irradiation of multiple small tumors allows us to use low irradiation scleral doses without damage to retina or choroid. And another mode is irradiation of preretinal vitreal seeds. And for very small tumors, we proposed a custom made collimator to irradiate small tumors. So the results of brachytherapy is rather good. Eye retention rate is about 91%, and 10 eyes were enucleated in our group because of severe progression of retinoblastoma, including anterior chamber, and complications like severe vitreous hemorrhages. There are several risk factors of brachytherapy insufficiency, tumor thickness larger than 2.5, tumor diameter larger than 7.3, scleral of course, and posterior location. Peripheral tumors do not give complications. And very important factor is time from intraarterial chemotherapy to radiotherapy. It should not be less than 3 months. Cryotherapy. We fulfill cryotherapy for peripheral tumors, and we use carbon dioxide and with double or triple freezing technique. So in general, local treatment outcomes. Complete tumor regression can be achieved in 76%. In 15%, we achieve partial tumor regression, and tumor progression in 7%, unfortunately, and 2% tumor recurrences. Local tumor control depends on stage. We can see that group A is 100% effectiveness, and group D is not so good for local control. And there are relatively big number of complications, and most of all, these complications are after radiotherapy or brachytherapy, and they include neuroretinopathy, hemorrhagic complications, cataract, retinal detachment, phthisis, and some others. The larger the stage, the more number of complications, that is obviously. Complications, risk factors include also using or not brachytherapy radiation. It is rather aggressive method. Number of methods used for treatment. If we use any method, the risk of complications is low. So in general, for all focal treatment, 93% of eyes were preserved, and enucleation was were fulfilled because of tumor growth or impossibility to visualization of tumors. So it is obviously that the same situation of dependence preservation of eye on stage. Group A can be the eyes in group A can be preserved in 100%, and in group D only in 82%. And what about survival? Our rate of survival in our patients 99%, and 4 children died. 3 because of trilateral retinoblastoma with CNS progression, and 1 patient because of esthesioneuroblastoma progression. And a special attention should be paid to conventional 2D so-called external beam radiotherapy. In 70s and 80s, it was a very popular method because of radiosensitivity of retinoblastoma and good results after radiation, immediate good results. But decades of follow-up of these children showed that there are numerous complications after radiotherapy. And nowadays, radiotherapy, external beam radiotherapy, is not in use for intraocular retinoblastoma. I underline that for intraocular, but it is in use for extraocular retinoblastoma. In Russia, we do not use EBRT since 2014. So complications. The most serious complications are midfacial hyperplasia. Here is a mother treated in 80s with EBRT and her child treated nowadays. We can see orbital deformity in mother. And the most serious complication that has been shown from after many years of follow-up is secondary cancers. This is our patient with the only eye, and this eye was saved, but the boy died because of disseminated esthesion and neuroblastoma. There were attempts to use more modern technologies of external beam radiotherapy, including proton beam, IMRT, stereotactic radiotherapy, but there are some difficulties in delivering, in using these technologies, and first of all, in narcosis, in numerous narcosis, and difficulty in planning. So presently, there is a problem of resistant or recurrent intraocular retinoblastoma that that cannot be treated by conventional approaches. And the question to enucleate, the problem to enucleate the eye arises. Sometimes parents refuse, so we proposed to use a single fraction radiosurgery as an eye salvage treatment. Since 2015, we treated 21 patients, 22 eyes, 17 of them by gamma knife, and 4 eyes with cyber knife. I underline that all these patients could not be treated by other approaches anymore, and they have all known treatment and systemic chemotherapy and local and laser and cryo and brachytherapy. And so there was a need to save the eye. According to technology of radiosurgery, this procedure will fulfill under general anesthesia, and the eye should be immobilized. We do it with 4 extraocular muscles suture fixation. After that, our colleagues of radiotherapy department in neurosurgery institution fulfill frame fixation or mask fixation in cyber knife technology. And there are 3 types of planning: to irradiate retinal tumors, to irradiate vitreal tumors, the whole vitreous, when the whole vitreous is disseminated by tumor, and combined approach where vitreous and retinal tumor exist. So according to these plans, the types of planning we fulfill after treatment, our treatment. Of course, we pay special attention for organs at risk in the eye, such as lens, optic disc, central retina, ciliary body, and try to minimize the doses and the radiation of these structures. A special attention we pay for dose distribution to orbital bones. As I mentioned earlier, the bones, the orbital bones of infants may be very sensitive and may result in orbital deformities. But according to our experience, it's rather difficult to compare different modalities of radiotherapy and to make straight comparison of proton beams and gamma knife radiosurgery. But according to our expression and our calculations, the irradiation and the doses on bones are less than in other EBRT modes. And this is the procedure of radiosurgery irradiation, and some cases of examples of effect of radiosurgery. This is one of the first cases. Monolateral retinoblastoma with group D, treated by systemic chemotherapy with no response. Enucleation was proposed, by parents refused. We tried to fulfill radiosurgery. Here is the planning of this situation, and we can see step by step resolving of a vitreous tumor to complete resolution. Another example of the child with group D retinoblastoma with chemotherapy and progression after this. Enucleation was refused and gamma knife radiosurgery was fulfilled using 50 gray on 50% marginal isodose. So the picture before gamma knife radiosurgery, 2 months, and 32 months after complete regression of the tumor. Another case of a very difficult situation with retinoblastoma upon the optic disc. There is no any suitable approach to treat this situation. Intraocular chemotherapy was refused because of ophthalmic spasm, of complication of intraocular chemotherapy. Enucleation, parents refused because of good vision, and gamma knife radiosurgery was fulfilled. So here is the planning with isodoses. It's not very big volume of irradiation, and the objectives of irradiation were to cover the visible tumor and to cover the adjacent part of optic nerve. Here's the plans, and after follow-up in several months, the tumor disappeared completely. One more case of recurrent retinoblastoma on the calcified masses, and of course, this situation, then this eye is a candidate for enucleation, but parent refused, and the gamma knife was successful. Another case of vitreal and retinal retinoblastoma after the different kinds of chemotherapy. unsuccessful, and we fulfilled gamma knife radiosurgery, and this is the plan. And tumor completely disappeared and regressed. Here is an example of our unsuccessful treatment, and there's a recurrent retinoblastoma near the calcified mass, and we tried to fulfill gamma knife, and at first, here is the planning. At first, we saw some resolving of tumor, but after several months, we considered the picture that it was a progression. But retrospectively reviewed this case, we are not sure that it was a progression, but it was just edema of the tumor, but the eye was removed. So this patient with bilateral retinoblastoma before radiosurgery and after in one eye and in another. And the example of cyber knife irradiation, the patient also with a tumor upon optic disc. This is a very difficult situation. No other approaches can be used, and cyber knife was fulfilled with good results and complete regression of the tumor. The two more cases of vitreous retinoblastoma regressed completely with stable result. So as to our results of radiosurgery, complete regression was achieved in 14 eyes, and tumor control was in 82% of eyes. Unfortunately, only 68% of eyes were preserved. But I would like to underline that all those eyes should be removed if there was no radiosurgery as a salvage approach. Of course, radiosurgery and radiotherapy in general is rather aggressive treatment, and we have rather a lot of number of complications, and all of these complications are intraocular complications, reactions for radiation. Among them, cataract, but this is not a big problem nowadays. Retinal detachment, the example before intraarterial chemotherapy, and total retinal detachment after. Neuropathy, retinopathy with different consequences, and retinal choroidal atrophy, and vitreous hemorrhages to the vitreous cavity. In some cases, these complications can be resolved spontaneously without any treatment. Like in these cases, radiotherapy is rather toxic for intraocular vessels, and it resulted in vitreous hemorrhages. But in all cases, it resolves spontaneously. Some vitreous hemorrhages may result in very severe fibrosis with possible retinal detachment. Here is a rather severe complication of central vein thrombosis. To overcome these complications, we proposed to use so-called subtenon infusion therapy. We use it only for the eyes with completely regressed tumors, and we use 22 G catheter, and through catheter we fulfill injections, infusions of steroids, angioprotectors, and antioxidants. This is the surgical procedure of injection of catheter implantation. And another way of implantation is subtenon implantation of catheter. Here is the surgical steps. We fulfill via lower eyelid, and then put the catheter into subtenon space. This approach can help to make resolving of complications more rapid, and we can use steroids several times per day, and effect of this approach is rather good, and this technology has no own complications. This is the situation after brachytherapy with edema, retinal detachment, and after subtenon infusion therapy, we see a complete regression. So the most often complication in radiotherapy is hemorrhagic complications. Vitreous hemorrhage may be the picture of tumor progression, or it may be the with tumor progression, or just vasculopathy. And in both cases, we have no visualization of the tumor, and we have no tumor control. So the question of enucleation arises. Of course, in some situations, we can make attempts to treat with medication, but in some cases, it is not effective. We fulfill surgery. Intraocular surgery for retinoblastoma or after retinoblastoma is rather challenging procedure because retinoblastoma has a high tendency to spread extraocularly. There was only few publications in literature concerning intraocular surgery, and our first patient, successful patient, was described in our paper in 2015. This patient had group D retinoblastoma after chemotherapy, EBRT, brachytherapy, and unfortunately, this text in Russian I missed to translate. So this patient had vitreous hemorrhage. This was the only eye, and we fulfilled vitrectomy, pars plana vitrectomy with silicone, and the eye was saved with not bad vision. But unfortunately, several months after, 22 months after the surgery, esthesioneuroblastoma was revealed, and as I mentioned above, this patient, and this patient died. So one more case of treated retinoblastoma with all kinds, with multiple attempts to save the eye, intravenous chemotherapy, intra-arterial chemotherapy, intravitreal chemotherapy, and progression. After that, we fulfilled for this girl radiotherapy, a gamma knife, and with good result. almost complete regression. But unfortunately, we saw vitreous hemorrhage that was not treated effectively, but retrobulbar catheter injection. So we fulfilled intraocular surgery by lancectomy, vitrectomy, and here's the picture after treatment, and the eye was saved. Another one patient treated by all kinds of known therapies, intravitreal, systemic, and intraarterial. We used brachytherapy with immediate good result. But after that, vitreous hemorrhage occurred. We tried to medically treat, no effect, and vitreous hemorrhage became more severe with completely obscuring the fundus and no vitreal, no tumor control. So we fulfilled surgery, and histology, there was no viable tumor and no recurrence within many months after that. So my presentation is ended, and I would like to talk that treatment of retinoblastoma currently cannot be separately either in cannot be treated either by pediatrician oncologists or ophthalmologists, and only combining efforts of several specialists, this problem can be resolved. And your director said absolutely right, that only multidisciplinary team can achieve success in treating retinoblastoma. So if you have any questions, I'm ready. I will try to answer. And I would ask audience, how many ophthalmologists are here? You, I know. Oh, okay. Oh, 3. Online, a lot of, I hope. So I repeat that my presentation and my experience based on ophthalmological experience. Only some features of radiotherapy or some pictures of radiotherapy presentation I can show. But I repeat then that retinoblastoma should be treated in a multidisciplinary approach. Thank you very much.
Thank you. Thank you, Dr. Andrey. So maybe next we will come to discussion, and you may sit over here, and we invite our ophthalmologists to discuss, Dr. Julie, and then Dr. Ludi, pediatric oncologist, and we have our radiation oncologist, Dr. Bobby. Dr. Bobby, please. So certainly your experience is very very helpful for us to think about how to solve a complex case like you and preserving eye. Maybe first I will invite Dr. Julie first to ask question, or maybe you have some opinion. Dr. Julie.
Thank you, Dr. Handoko. Thank you for Dr. Andrey for your interesting presentation and very insightful for us. Now, Okay, maybe I just want to share a few. Indonesia has several hospital for retinoblastoma center, but here RSCM is until now is more relative complete. Yeah, but unfortunately we don't have modalities of treatment like your presentation brachytherapy. Yeah, we just do external beam radiotherapy for extraocular case. Yeah, and until now we just do the for local chemo. We just do the intraarterial chemo by interventional radiologists. Yeah. And we are from ophthalmology. We just do the focal therapy, yeah, laser, thermotherapy by diode laser, and also enucleation for the advanced stage. Yeah, and can I have a question? Yeah. Okay. My question is, in your presentation, you did several case with brachytherapy. My question is, do you put brachytherapy as first choice of treatment for early stage of RD, or after we do the chemo, local chemo first, or focal therapy first, and if the result is not good, then we choose the brachytherapy for the treatment?
Thank you for your question. And we do, and we fulfill both approaches. If it is retinoblastoma of group B on the periphery of the fundus, and the size of the tumor is too large for laser, we fulfill brachytherapy. And if retinoblastoma is too big for brachytherapy, we use chemotherapy. And the size for the tumor size for brachytherapy should not be larger than 4 to 5 millimeters in thickness, because the larger the tumor, the higher the steroid doses, the higher the risk of complications. And I have missed. Do you fulfill laser treatment in your clinic? Yes. We have in Russia one clinic that also fulfill chemotherapy, local chemotherapy, intraarterial, intravitreal, but do not have brachytherapy in St. Petersburg. But they fulfill laser and cryo, which is a rather successful way to treat retinoblastoma, to deal with the retinoblastoma when there is no brachytherapy. So technology of laser treatment and cryo treatment is not very difficult, and apparatus for either laser or cryo is not very expensive. So it can be, patients can be treated even without brachytherapy selected cases. And this is a system of treating retinoblastoma using local chemo, systemic chemo, laser and cryo is a good variant for treating retinoblastoma.
Because the problem of our patient is they always come in advanced stage, yeah, or maybe in group C, group B advanced, the tumor is very high. Sometimes we cannot do the laser optimal, and the response is very low. Yeah. So at the end, we refer the patient to pediatric oncologist anymore to do the chemosystemic again. But there is also a limitation in administering the systemic chemo because the side effect of the long-term chemo. So sometimes it is difficult for us to manage the patient optimal. Yeah, maybe Dr. Ludi.
And many years ago, we had the same situation when no conventional approaches can be attempted, and chemo and not EBRT. So we try to use radiosurgery, and maybe it is a way, an option to overcome the necessity to use brachytherapy, but not for small tumors, but not for, and as a eye salvage treatment. Maybe it will be.
Thank you so much, Doctor, for your interesting presentation. But I want to ask about what about the outcome after brachytherapy and gamma knife surgery, radiation surgery, something like that. Maybe about how the vision, about the vision, and maybe is there any relapse chance after procedure?
To the last question, of course, the relapse can be shown after any treatment in all fields. And of course, radiosurgery and radiotherapy is rather toxic for powerful structures and vessels and so on. And the vision level strongly depends not only on radiotherapy and doses. It depends on tumor size, tumor location, and so on. And preservation of vision is a very important task. But this is the third task. The second is preserving the eye. So if we can preserve the eye without vision, we do try to preserve the eye.
Okay. Thank you, Dr. Andrey, for the lecture. So, we don't have any experience regarding application of brachytherapy for the eyes in here. And I'm very interested regarding the setup of brachytherapy, how to set up our brachytherapy so that we can apply the plaque brachytherapy for the eyes. This is my first question. And then also, in your experience, you mentioned that the thickness of the lesion should be less than or equal to 5 millimeter. I read some papers that they can be applied up to 9 millimeter of the thickness. So the questions, what modalities of brachytherapy source do you use or your center use? We know that we have like iodine with we can the penetration is deeper, and then the 1 month of half-life, or ruthenium, which has a longer half-life of 1 year, but it has a shallower penetration. So or even cobalt. I don't know is there any centers that use cobalt for the plug. How do you think, Dr. Andrey?
As I know, the majority of eye centers dealing with retinoblastoma and who use brachytherapy, they use ruthenium plugs. Iodine plugs is in use mostly in Northern America. And for retinoblastoma, the optimal plug is, the optimal source is ruthenium. because there is no need to irradiate tumors thicker than 4, 5, 6 millimeters. Those tumors should be attempted to treat by chemotherapy. And ruthenium is quite a mild source with relatively low energy electrons, with very limited complications. All those complications that I have shown, they can be overcome by modern technologies. The main problem of brachytherapy, I think so, according to a Russian experience, is the licensing of this kind of sources. To have a license for radiotherapy is rather difficult in Russia. And if there is a license for radiotherapy, to get extension for another source, I think it's not a very big problem. The second item that ruthenium plugs is not extra expensive. It's not extra expensive. The half-life of ruthenium is 1 year. So we use ruthenium plugs within 1 year or 1.5. And the Russian plugs we use about 2 years because it's they have greater dose rate. And the third issue that in our life, in our medical practice, we do some first step in some moment of our medical practice. And maybe this step maybe can be made. I know that, for example, no many years, or maybe 1 or 2 years ago, brachytherapy has been introduced in Thailand. As I know, for the first time in Southeastern Asia. And they did this first step. So if there is a need to use show, I think that the possibility can be found.
So after, like let's say, apply the ruthenium for like 1 year or more than 1 year, and then you evaluate the response is very good. Do you take out the plug or it stay there? Take out.
I didn't catch you.
So after you applied the plug, the ruthenium for like 1 year or more than 1 year, and then you evaluate the response, then it has a very good response. So do you remove or not?
Oh, we apply a plug only for several days. For 1, 2, maybe 3 days, and not more. And then we remove the plug, and it's repeatedly used within 1 year or 1.5 years. So it's a multi-usable source. Yes, just to sterilize and to have a place for storage of this radioactive source.
Thank you.
Except of retinoblastoma, we use plugs for uveal melanoma. And if we treat retinoblastoma by brachytherapy, I think maybe every week or once a week or once 2 weeks, Retinoblastoma, uveal melanoma, we treat with plugs every day and several patients a day. So there are situations when our plugs have no possibility to be stored in our safe, and just to sterilize and to remove to other patient, and in 7 days or in several days we remove, and next patient, and so on.
Where do you put the plug? On the sclera, out of the sclera, or under the sclera, between sclera and choroid?
No. Between the sclera, at the surface of the sclera. It's not intraocular surgery, just to
Like buckling.
open conjunctiva and tenon cover and place at the surface of the eye.
And how about the position of the tumor? Do you do the plug brachytherapy only for anterior?
It's a very good question of ophthalmologist that understand the problem. Yes, if we treat uveal melanoma, especially pigmented tumor, we see the shadow on the sclera by transillumination. But retinoblastoma is non-pigmented tumor, and this is a rather a challenge to find a proper position for plug. I have no time to show our experience to use some light pipes that we can find with ophthalmoscopy the location of the tumor, to mark at the sclera this point, and to put the plug right on above the tumor.
How about the tumor in the muscle?
Yes, of course, but we have no choice. Yes, very posterior. We in sometimes we rotate the eye. In some time we cut the muscle and then reposition. And this is also a very challenging problem. And we use specially designed devices with light pipe to find the position of the plug. Yes, by sutures.
So maybe we give the time for the audience, maybe audience or anybody from the Zoom want to ask questions. Any no, Zoom, no? So anyone here want to ask question? Yeah. Yes, please.
When I was read your presentation, there are some centers in Russia. They are saying that you do for the retinoblastoma like 3 times brachytherapy and then 2 times SRS like that for gamma knife.
Maybe louder, please.
When I read your presentation, there was in Russian language, they are saying like that you did 3 times brachytherapy and then after that 2 times SRS. For my question, if I'm not wrong, because I was read that. My question is how about the doses, and then how about the irradiation you did for the patient, and then how many maximum dose we can give for the patient? Because like we still has to thinking about the organ structure beside the tumor, right? Okay, thank you.
Thank you. You know, this is also a real challenge because you know what is therapeutic interval. To give too high dose, there will be complications. To prescribe low dose, there will be incomplete tumor resolve and so on. So we find the optimal dose, and when we use for the first time radiosurgery, neither we nor experienced radiotherapists did not know what dose to use, and they presumed that the dose that they prescribe for brain metastasis will be enough for retinoblastoma. So we choose 22 gray on 50% marginal isodose, and it's very difficult to decide to prescribe lower dose, because for example, it is the last eye, the only eye, and this is the last possibility to save the eye. And if we prescribe low dose, we can receive unsuccessful result. If I answered your question or not?
University, right? Like it's according your experience in university that you adjust it according to patient. There is not like a real how to say a clinical recommendation for the dose, right?
You know, we have a rather small amount of patients, only 22 irradiated eyes. So to differentiate the doses is rather difficult. But according to our experience in vascular tumors, we see that the doses can be reduced. So maybe we step by step will try to reduce the doses. So, and nowadays there are no universal recommendation what doses to use, but maybe universal recommendation to use 20 gray on 50% marginal isodose in radiosurgery.
So your 22 gray in 15% marginal dose, that will be so high for the surrounding retina. So you are not preserving vision anymore at that point.
It depends on location of tumor. Yes, if this is a peripheral tumor, no damaging of central retina and vision. And if it is a central located tumor, the vision is lower.
Yeah. Okay. Dr. we want to ask this, please. Yes.
Still in topic about the dose with the SRS. So I kind of thinking that you know that retinoblastoma is one of the quite good response to the radiation, to the radiotherapy, quite good response. I mean, how do you consider to reduce the SRS dose? Because if I think that like 22 or 24 gray for SRS is like same to the low grade brain tumor or like meningioma or something like, but this one is retinoblastoma is quite responsive. How do you think to reduce the dose of the SRS?
You know, we are afraid to reduce the doses, but it should be reduced step by step in every next patient. We will try to use 20 as now, as currently, maybe 18, but we are very responsible for the outcome and for the preserving the eye. So it's rather difficult question.
Or probably you can make a hyperfraction morning and evening session
Yes, but to irradiate the retinoblastoma children, as a rule, is small children, you know, it's a problem to make general anesthesia and to make planning, similar planning from procedure to procedure. That is why, but hyperfractionation irradiation should be not so aggressive.
Okay. Okay, thank you. Any? Okay, please, Dr. Stefan. You use this one.
Thank you, Doctor. Can you share us the system in your country, how you can screening the early stage of retinoblastoma, where it gets still so small tumor? Because in our country, maybe already discussion that we get advanced stage. So in your country, how you do the screening system so you can get the early stage of the retinoblastoma? Do you have a screening like you do it yearly for the child or do something like that so you find the early stage of the tumor? Can you share? Thank you.
You mean screening for all children?
Yeah. Is there any system in your country to do that?
Oh,
so
I see. Yes, there is a law to make a screening for all newborns after 1 month after the birth. So every doctors, every clinics try to do that, but we have also patients with group C and D and even E, and the majority of cases not the initial stages, despite the system of screening. It depends not only the system, but it depends on parents and how do they fulfill these recommendations.
Okay. One more question over there.
Thank you so much, Dr. Andrey. Thank you for your presentation. I would like to ask question. The first one is for your patient who underwent the gamma knife radiosurgery. Do they still have the vision prior to the GKRS or they already lost it? And if they lost it due to the GKRS, what are most possibly be the causes? Is it because the destroyed retina or the glaucoma caused by the radiation? And I would like to ask, is it as an ophthalmologist, is it possible to perform surgery, for example, like trabeculectomy or the other surgery? So the radiation oncology will have like a looser constraint for the lens, maybe for the glaucoma, for the eyeball, in order to give more doses to the tumor. That's the question. Thank you.
Thank you. And the first question, can you repeat? It's not
for the patients who underwent the GKRS, the gamma knife RS,
about vision.
Yes.
About the vision. Do they still have the vision prior to the procedure, or they basically lose it because of the procedure? And if they lose it, is it because of the glaucoma or maybe just the damage to the retina? Thank you.
As a rule, and not as a rule, but all our children treated with gamma knife or cyber knife were heavily pre-treated by other treatment options. And almost all of these cases, almost not all, have damaged retina prior to irradiation. But we have a boy about 8 years old at the moment of treatment where retinoblastoma resolved completely. There was no such, but we have an excellent vision, and OCT showed absolutely normal macular region and fovea with high vision. But several years after radiosurgery, he developed a vitreous hemorrhage. We saw some cases with very, very late onset of hemorrhagic complications. And this is a rather interesting and not quite clear item for us. The problem of hemorrhage occurs very, very late, after several years. So radiosurgery is a rather challenging procedure, but it can be the last option to save the eye. So, and in these cases, the vision is not the first task for us. According to question about glaucoma surgery, we do not use surgical treatment for secondary glaucoma in those patients, and I don't know a wide experience in that. I know our patient who was treated with treated retinoblastoma without any signs of viable tumor and secondary glaucoma. We tried to treat him with cyclophotocoagulation. But we fulfilled only one procedure, and they went abroad, and there he was treated by retinal surgery and so on, and we do not know exactly the outcome. But no intraocular procedure in retinoblastoma are not allowed because of the very, very high risk of extraocular extension.
Okay. So you want to ask a question? Maybe so maybe a short one, okay? Because how you short.
Good afternoon, Dr. Andrey. First of all, thank you so much for your insightful presentation for us. For the first question, I would like to ask, even though this is a very localized treatment that you've been presented for us, I'm so curious whether is there any side effects or vision disturbance for the contralateral eye? Also, for the second question, during the follow-up period, is there any vision rehabilitation that the patients receive after the local treatment to optimize the treatment? Thank you.
Limitations, what limitations?
For the second question, is there any vision rehabilitation to optimize the impact of the local treatment? Thank you so much.
We have never seen any problem to the fellow eye over radiation, and the calculations and planning show that there is no radiation, absolutely no radiation in radiosurgery. And concerning rehabilitation, it's no real ways to rehabilitate the damaged retina. We, in some cases, we recommend to occlude the better eye and try to improve the vision in the but it's not very, very successful. But in some cases, it can work, especially when the vision of both eye is very low. So to stimulate the vision, we recommend to do that.
Thank you so much.
Thank you so much, Dr. Andrey, and all the panelists. Thank you for discussing this important treatment for retinoblastoma. So maybe we have any photo session before. Bro, sorry. Yeah, bro. One question. Bro.
No, I mean, yeah, I just want to make like a closing remark maybe, because you are talking about the ruthenium and strontium, right? Actually, in the past time, I have a plan to provide the both of the modalities. I mean, the plaque brachytherapy, but the problem when we do the cost benefit analysis, it is not become cost effective in our countries. Why? Because the case is very rare. The lesion with not more than 5 millimeters is very rare. So it is not, so if, I mean, to Dr. Julie, maybe if we want to invest to have that kind of modalities, we have also to invest how to do the screening for the early retinoblastoma. That's the first thing. And the second thing is about the gamma knife, about the SRS. We have here the SRS, but I don't think that it is good for our pediatric patient because of the energy of the cobalt that we have here. It is not belongs to us. It is belongs to the neurosurgeon. Because of the energy of the cobalt energy in the gamma knife, Handoko know that.
Yeah.
For the treatment, it takes like more than 5 hours. That's a very minimal time. The maximal time can be 14 hours, right? Even more than 14 hours. And I saw the picture that for the gamma knife, we know that we use the rigid frame. So that means it's not possible for the kids to be under the anesthesia for such a kind of so long time. But we have another, if it is maybe it is better using as you have the cyber knife, because cyber knife is without the rigid frame. But here, and also in other center, for example, we have the X knife. So it is something like the cyber knife, but cyber knife is really dedicated for the stereotactic, and the other X knife, we use the linear oscillator. For such a kind of dose, maybe it takes only 30 minutes.
Yeah.
Yeah, and also we don't use the rigid frame. We use the double mask, so we can do it with the shorter time. And actually, I would like to ask, I have one question between the strontium and ruthenium. We know both of those radioactive, it is a beta emitter, right? Beta, so it will produce the beta X-ray, beta ray. So, but the energy is very different. The keV, the ruthenium is just only 10 keV, kilo electron volt, and the strontium is almost 200 kilo electron volt. But on the other hand, ruthenium half-life is like 1 year, and the strontium is something like 29 years. Yeah. So based on your experience, which one is more cost benefit using the strontium and the ruthenium? Cost effective. Cost benefit. Yeah.
You know, we use strontium plugs since Soviet Union.
So we don't need to exchange, right? If we use the strontium, because the half-life is 30 years,
Yes.
almost 30 years.
It will be enough for us and for our children. It's very long, and to buy once, we can use this for many years. And but ruthenium should be
every 1 year.
Every year, maybe every year. So you're quite right then to make a decision to use brachytherapy or not, maybe should be based also at the cost effectiveness and calculation of money. If there is only a few patients per year, there's no reasons there are no reasons to have brachytherapy. And that is why, in our center, eye microsurgery, we have 10 branches all over our country, from Far East to St. Petersburg and so on. And there was multiple questions to introduce brachytherapy in some far branches in order the patients not go
Far away.
through 8,000 kilometers to be treated with brachytherapy. And it was not adopted truly. It was correct, because in far regions, there are few patients. It's better for patient to come to the center where those patients are accumulated. So you're absolutely right.
But between strontium and ruthenium, which one is more cost effective?
Cost effective. Oh, it's in Russia, one strontium plug costs like 5 ruthenium
Oh,
plugs.
cool. Okay. So
So
it's more expensive. Yeah.
yes, but we can use it much more longer. So I have never calculated this problem of money, but one strontium plug costs like 5 approximately, like five ruthenium plugs.
Okay. Thank you.
Okay, thank you. So perhaps we can have one last photo session together. Prof. Tati, maybe. Okay, you may sit. Hey, you may stand in the center.
Higher ruthenium, higher energy of that. No, that is one. That is let's see. That is why we can treat by strontium only 3 millimeters, and ruthenium up to. Right? Yeah, we do that. Yes, really. Surgery in order to prevent recurrence.